Hi everyone, good evening. So welcome to the 10th session of Teach and Learn classes. Today we'll be having the second session on ECG. In the first session we covered the basics. So the video of which is uploaded on YouTube. I forwarded the link to the groups. So sorry for posting it a little late. It took a bit of time getting it ready for uploading. So today we have Dr. Chaitanya, who is an assistant professor in the Department of General Medicine and DRNB hematology resident at St. John's Medical College Hospital. We all know him very well. So I really welcome you, sir, to this class. As usual, the reminders, please keep yourself muted. If you have any queries, you can type it in the chat box, also on the discussion group, WhatsApp group. So those who have not joined the group, I will, if you request, I'll put the link so that you can join. And also any questions related to these classes or after the classes, you can put up the group for discussion. And we will be sharing a feedback form in between the class after the main session is over. Please go and put up the feedback, and then we'll resume with the discussion of ECGs. Is that okay? Okay. So over to you, sir.
Thank you, Namita. Again, very kind introduction. So the second part of ECGs, I thought I would, after you learned the basics last week, and now that the video is up and as you guys have had some time to probably read it again, hope springs eternal. You will have a little bit of an idea on how to read a basic ECG. Today's class will focus on two of the biggest challenges that all of you will face, or all of us face, which is diagnosing acute coronary syndromes and identifying arrhythmias. Chamber hypertrophy and miscellaneous I may not have time to touch upon, but definitely ACS and arrhythmias are the two most critical things that any doctor, irrespective of what field they're in, should know how to identify. As I said in the last class, and I'll reiterate, it's important not to miss a big finding. You miss a small finding, you don't pick up a subtle finding, that's okay. But missing a life-threatening arrhythmia, missing an acute coronary syndrome, however subtle it may be, is something that we should completely avoid. So that's what I'm trying to do in this class. And I've put basically every ECG has a case. So, there's a little bit of history in which you read an ECG, which tends to also add to it. In the days of, where we look at reports and treat them rather than look at patients, it still becomes critical to look at the patient's presentation when you're looking at an ECG. This is just a brief recap from last class on the ECG checklist, which all of you are familiar with. But as I mentioned last time, always look at the standardization, which is important to look at 2 big boxes in length and 1 big box in width. Look for the PQRS wave, look at the PQRS waves, calculate the heart rate, look at the intervals and segments and the T waves in that particular order. The reason I put up the ECG checklist again is to basically emphasize that if you read an ECG, follow a particular format. This format is easy to apply because it basically follows an electrophysiological pattern. But once you start doing this and you do about 10 or 12 ECGs with this particular checklist, you'll make it a habit. And once you make it a habit, you will not miss anything which is gross. So this is just basically a revision of the checklist. These are the steps that I request all of you to follow. And this is something that I think is extremely important. Calibration or standardization is first. Calculate the heart rate, look at the rhythm, whether it's sinus rhythm or not. What is the axis? Then you look at PQRS ST waves, the classical ST segment, which is the most important segment, then the PR and the QT interval. If you follow these 7 steps, then you can come to a significant diagnosis. So it's important to follow these steps. Even if the ECG is grossly normal or even grossly abnormal where you know the diagnosis, it's worthwhile going through these steps just to ensure that you meet completion. So coming to acute coronary syndrome, which is the first part of today's class. So classical history here, we have a middle-aged man with significant smoking history who comes to us with left-sided crushing type of chest pain for the last 2 hours with sweating. Now, again, as I keep mentioning, and when I teach acute coronary syndrome, you will only get about 1/3 of patients with this classical Levine sign and angina chest pain. 60% of patients with acute coronary syndrome, especially women, elderly, and diabetics, tend to come with an atypical presentation. He had a pulse rate of 90. A BP was slightly on the lower side, 170. I say lower side because if he's got such severe pain, I would expect sympathetic overdrive and slightly higher blood pressure. Slightly tachypneic at 27, probably pain related. He's very restless and he's profusely sweating. All the classical features of an acute coronary syndrome. And this is the classic ECG that you've seen. I put this up in the previous class, but this is the classical ECG that we see in this patient. So if you look at this ECG, as I said, the first step is always standardization. So you have to look at standardization. Your eyes should automatically drift toward the left side of your ECG to look and see that it is two boxes, that is two big boxes in tall and one big box wide. Next, if we have to look at the heart rate and we look at lead 2 for the heart rate, because that's the most physiological lead corresponding to the electrophysiological vector, it's approximately 75 beats per minute, which we saw. You look at the axis, one is positive, AVF is biphasic, so you can leave it as probably a normal axis. But what we are looking at here are some gross abnormalities. So if you look at the gross abnormalities that we see here, you can see that there is ST elevations. And these ST elevations, again, are classic ST elevations, which you may not see in every patient. Again, maybe about 25 to 30% will have this classic ST elevation. And you can see the ST elevation in V1, V2, V3, V4, V5, and to some extent in V6 as well. If you look very closely to the ECG, and before the panic sets in that this is an MI, what do I need to do? Where do I need to refer them? Do I give loading doses? Always just look at the ECG again, and you'll notice that in AVL, which is on the top left of the screen as well. I'm sorry. If you look at AVL, I'll just put on the laser. If you look at AVL, there are some ST elevations in AVL as well. There are also mild ST elevations in lead 1. So if you remember my teachings from last time, I said that V1, V2, V3, V4, V5, V6 generally form the anteroseptal wall of the left ventricle. V1, V2 is the septum. V3, V4 is generally the anterior wall. V5, V6 with one AVL becomes the lateral wall. So if you look at it, this patient has ST elevations in almost all leads, V1 to V6 as well as one AVL, which means it's involved the septum, the anterior wall, as well as the lateral wall. So this is an extensive anteroseptal and anterolateral ST elevation myocardial infarction. And you look at the findings that I've pointed out, that you will see two more findings that possibly we would have all missed if we were focusing on the ST elevation. One finding is if you look carefully, especially in V1, you can see a very prominent Q wave. Right? And this Q wave, as I told you last time, generally Q waves, if they are more than 1 mm in depth, we call them pathological Q waves, right? And if you look at V1, you can see the pathological Q wave in V1. Now, this pathological Q wave indicates death of myocardium. ST elevation indicates ongoing death of tissue ischemia. The presence of Q waves is already dead myocardium, which means by the time this patient has come to you in that 2-hour period, there's already been loss of some amount of myocardium. So a Q wave always indicates myocardial death. The other thing that you may notice is that the PR interval, as I told you last time, we calculate the PR interval as from the beginning of the P wave to the beginning of the QRS complex. And anything more than 5 small boxes or 0.2 seconds is significant. Here it's about 6 boxes. So there is an associated first degree AV block. Does this add? No, it is part of anteroseptal MI. Some patients with a septal myocardial infarction, there is transient AV nodal ischemia. But this is something to keep an eye because this is the patient who can progress from first degree to third degree. And if they develop third degree or complete heart block, then an urgent pacemaker insertion is usually required. So this is classically called tombstoning, as I told you, because it looks like a tombstone. It's also called tombstoning because of the macabre sense of humor that doctors have, that if it's a tombstoning ST elevation, the mortality rate here is close to 90% if not treated early. So these are patients where you have to refer for an urgent percutaneous coronary intervention or thrombolysis in such situations. So one slide on the definition of STMI, which is something I think all of you should know. So the presentation with persistent findings of more than 20 minutes in 2 contiguous leads. Now, this definition, which is the most recent definition, has added time. And it's so odd that you have an ECG definition with time. And this is why I mentioned that you should always do serial ECGs. Whenever you have a classical ST elevation MI, that's fine. But if you have a presentation where you're doubtful, always repeat the ECG. Because if you see changes which are persistent or which are progressive, you know your diagnosis is myocardial infarction. So any ST elevation of more than 2.5 small squares in leads V2 and V3 in a man under 40, or a man over 40, 2 small squares enough, or 1.5 in a woman in V2, V3. So we are only looking at V2, V3, 2.5 if the man is under 40, 2 if the man is over 40, more than 1.5 if it's a lady. This presentation tells you that this is ST elevation MI in V2, V3. But you take any other lead in the body, 1 AVL, 2, 3 AVF, V5, V6, more than 1 mm ST elevation in 2 contiguous leads is more than enough. Now, what do you mean by contiguous? So there's difference between contiguous and continuous. Contiguous means leads which supply the same or reflect the same arterial territory. For example, V1, V2 septal, V3, V4 anterior, 1 AVL, V5, V6 lateral, 2, 3 AVF inferior. So contiguous means the ECG leads which correspond to a particular chamber, and that is important to look at. The last point I think is very important, which is any new onset left bundle branch block. If the patient has no previous ECG and they come to you with similar history and you have a LBBB, assume it's an MI entry. Only if you have a previous ECG which shows the same findings can you say that this is a prior LBBB. There is a criteria to say ST elevation in LBBB called Scarbosa's criteria, which may be a little too much for the purview of this class, but please remember LBBB to be kept in mind. So this this slide shows you what I was talking about in terms of which leads correspond to which arterial territory. So 1 AVL is and V5, V6 are lateral wall of the heart, which is generally supplied by the circumflex artery. In some patients, it can be supplied by the right coronary. V1, V2 is septal, V3, V4 anterior, supplied by the left anterior descending branch of the left coronary artery. 2, 3 AVF is the inferior wall supplied by the RCA or LCX. Right? So remember, right coronary artery and or LCX supplies the inferior wall. Left circumflex or sometimes the LAD diagonal, very rarely the RCA supplies the lateral wall as well. V1 to V4 is the left anterior descending. Now in our patient, he has lateral wall involvement, he has anteroseptal involvement, which means that both the left circumflex and LAD are involved. Both are branches of the left coronary. So this is the patient who has a left coronary disease. The main coronary artery or LMCA is involved, which is a very bad prognostic factor to us. Right, coming to ECG2. So an elderly lady who was a known diabetic for the last 10 years was brought to your emergency with a syncopal episode, which lasted for about 10 minutes. So they said syncope, but she's been slightly drowsy for about 10 minutes. And for the last 1 hour before that, she was complaining of severe tiredness and was quite restless. Because of this, you examine her, you find that she is bradycardic with a pulse of 54 despite being restless, a blood pressure of 80/60, which you have rechecked manually. She's drowsy, you find that she is sweating, and her JVP is elevated. So she looks like she's got evidence of heart failure. And this is the ECG that you see. Okay. Now, if you look at the ECG, your eyes should obviously first go towards the calibration. And the calibration in this particular patient is normal. 2 boxes tall, 1 box wide. Calibration is normal. Next, if you look at the heart rate, approximately the heart rate is about, if you look at lead 2, between 2 RR complex, there are about 6 boxes. So the heart rate comes to around 50, which is what we calculated in the beginning. So it's about 60, 50. The axis 1 is positive, AVF negative, so a left axis deviation. Now, what is grossly abnormal when you look at the ECG? If you look closely to 2, 3 AVF, you can see ST elevations, right? You can see ST elevations in 2, 3, and AVF. You can also see some ST depression in AVL as well, right? Which is something you don't expect. But here you can see ST elevations classically in 2, 3 AVF, which are concave upwards, right? Now, this is important because you can also see the presence of, as I showed you in the previous ECG, a Q wave, which is present in leads 3, also present in lead AVF, but predominantly in lead 3. So you have a Q wave, which indicates myocardial death, ST elevation, which is ongoing myocardial infarction, and what we call OMI, or a reciprocal change. A reciprocal change is a change that occurs in leads apart from the involved leads, reflecting myocardial ischemia. OMI is occlusive myocardial infarction, a slightly older term used, which tells you that the myocardial infarction, the blood vessel that it is involved, is pretty stenosed. There is not too much collateral supply. So there is a spillover of the ischemia to the lateral wall in this case. If you don't pick that up, that's fine. But if you identify the ST elevations in 2-3 AVX with the Q wave, it tells you you're dealing with an acute inferior wall ST elevation myocardial infarction. That is your full diagnosis. The bradycardia can be sometimes an inferior wall myocardial infarction. You can get bradycardia. Again, it could be related to transient AV blockade, or sometimes, very rarely, it could be the sinus node getting in. As I showed you in the last class, these are all the patterns of ST elevation in the ECGs that you can see. Right? So you can have a peak T wave, which sometimes most of us miss, which is the first sign of, it's called a hyperacute MI or hyperacute phase of MI. Then you have the progression of the ST elevation. You have a upsloping, which can be a sharp upsloping, a convex sloping, or even a plateau phase. Then you have the Q wave, which is the formation of which reflects dead myocardial tissue. Then the ST wave elevation starts to settle with T wave inversions. And eventually, once the myocardium recovers, the Q wave will be persistent, which tells us how much myocardium is dead. And the T waves eventually normalize along with the R waves. Right? So this is how it progresses with the times mentioned on the right side of the slide, which tells you. So it's ideal that you pick up a patient in the peak T wave. It's ideal, but you should never miss a patient in stage 3. If you miss a patient in stage 3, you are often going to lose myocardium. As I told you last time, time is myocardium. Same thing as I showed you last time, the patterns of ST elevation. Our patient classically followed pattern 2, but you can see any of these patterns are evidence of myocardial infarction, ST elevation type. Coming to slide 3, we have an elderly gentleman who was a known case of hypertension, and he comes to you with history of worsening angina. And for the last 6 hours, he's unable to lie flat. He's got what we call orthopnea, which you've all heard in your medical postings, which tells you that there is left ventricular failure. When you examine him, you find his blood pressure is 160 by 100, pulse of 96, tachypneic, possibly because of the orthopnea, elevated JVP, which tells you that the patient is in heart failure, and there is no edema present. Okay? So this is the classical presentation that you see. And these are the ECG findings. So again, I draw your attention to show that the calibration is normal on the left of your screen. Two long boxes, two boxes tall, one box wide. The axis, lead one is okay. AVF is predominantly left, so this is a left axis deviation. The heart rate is approximately 3.5 boxes, so slightly less than 100. And what you can see here are two important findings. One important finding I'll draw your attention to leads 1 and AVL, where you can see that both 1 and AVL, there is ST elevation, right? You can see that there's quite a sharp elevation of the J point, and this is ST elevation in 1 AVL. But what you can also see is you can see ST depressions. And these ST depressions are present in lead 3, they are present in AVF, they are present in V1, V2, and V3. So you can see ST depressions in these leads. Now this may confuse you. You got one AVL ST elevation, so you said, yes, this is ST elevation 1 AVL, this is a lateral wall myocardial infarction. But why am I getting ST depressions in 2-3, in 2 AVF and V1 to V3? A lot of people have asked me, is this a mixture of STEMI and NSTEMI? Can the same patient have STEMI plus NSTEMI? Not really. These changes are called reciprocal changes. The ST elevation, as you've classically identified, is persistent. But the reciprocal changes which are present tell you the degree of occlusion. And as you know, as I told you, one AVL is the lateral wall supplied by the left circumflex. In about 20 to 30% of our population, the left circumflex also supplies the inferior wall. So that's why you're seeing inferior reciprocal changes in 2 AVF and V1 to V3, because probably this left circumflex is the dominant vessel supplying the right side of the heart as well. Again, this is a rare finding. Does it change your management? No. Will you still give loading dose of statins and antiplatelets? Absolutely correct. But this tells you that this is an occlusive myocardial infarction. So the urgency to shift a patient for thrombolysis or to a near center for percutaneous coronary intervention or a angioplasty is paramount. Whenever you see OMI changes, please ensure that the degree of urgency you show to refer them is much higher. One word on that. OMIs are branches where there is a near or total occlusion of a blood vessel, where the collateral circulation is insufficient. Whereas the NOMI, which is a non-occlusive, here the vessel is not occluded fully, right? The plaque is only partially obstructing the vessel, or the vessel has enough collaterals which are taking care of the blood vessel. So patients with OMI are urgently required because they do well once you remove the. So again, this is just a graph which I showed you. This shows you if you reperfuse, how important it is. And this is something I tell all my students, especially those in the bond centers. When you figure out which bond center you're working at, always figure out which is the closest hospital which does thrombolysis, closest hospital which does PCI, because time is myocardial. If you look on the screen, you will see that this is the normal progression of a patient with MI. So they have hyperacute wave, ST elevation, Q wave, T wave inversions, and recovery. This is if you leave the patient without any dramatic intervention, or this is the natural progress of the disease. But if you look below and you reperfuse, there are three places where you have a window to reperfuse. Hyperacute T waves, which we rarely pick up, ST elevation, and when the Q waves start to develop, which means within 12 hours. 12 hours is an upper limit given travel. Ideally, 60 to 90 minutes, the patient should be in another hospital for an intervention. But the upper limit is still 12 hours. You still have time in certain patients. Certain patients, they don't even give you minutes to save them, as some of you may have experienced. But why I've put this graph up is to show that if you reperfuse, you can save the patient from Q waves. And if you look at the degree of reperfusion that we've done here, eventually the patient, if you reperfuse early, may not lose myocardium, may not develop global hypokinesia or septal hypokinesia, may actually be saved from long-term morbidity or mortality. So that is why reperfusion and identification is super. A male patient who's, this is ECG 4, a male patient who's a known case of chronic obstructive pulmonary disease is admitted with pneumonia. So he's admitted under you with pneumonia. You are on duty, you get a sudden call saying that he's complaining of chest tightness, breathing difficulty, and his oxygen sats have suddenly dropped. So two things or three things jump to your mind. Is COPD, is it an acute exacerbation with worsening of the underlying respiratory problem? Second, his COPD, he's immobilized because he's breathing difficulty. Has he developed a pulmonary embolism? And third, is it an acute myocardial infarction? Because MIs are much more common in patients who have an underlying lung disease due to the pulmonary dynamics. You see the patient, he's tachycardic at 146, BP 120/80, he's tachypneic, he's hypoxic, right? His JVP touchwood is normal, and you can see no edema. So you immediately give nebulization to relieve the bronchospasm, and you ask for an ECG. And your ECG shows this. So if you look at your ECG, again, the calibration is not very clear here, but we'll assume it's normal. The heart rate is quite high. If you look at the heart rate, it's approximately 2 boxes. So 300 divided by 2 is about 150, which is quite significantly high. His axis is okay. And if you look carefully, in addition to the tachycardia, which is quite obvious, you can see that in this patient, if you look at 1, 2, AVF, V4 to V6, and even to some extent in V3, you can see ST depressions. You can see very clearly, if I bring your eyes to V4, you can clearly see where my pointer is the ST depressions. And if you look, there are ST depressions in 1, 2, AVF, V4, V2 to V6. So these are diffuse ST depressions. And if you look at AVL and 1, you can also see the T wave inversions. 1 AVL and in fact the lateral leads as well, V4 as well, you can see T wave inversions. So you have tachycardia, you have ST depressions, and you have T wave inversions. So when you see this particular situation, your diagnosis is non-ST elevation myocardial infarction. Please remember, ST elevation is elevated. ST depression, the ST segment comes down below the baseline, and it can have T wave inversions in the same leads. And remember, ST depressions and T wave inversions indicate NSTEMI. And NSTEMI does not necessarily follow an arterial territory. Like with STEMI, 2-3 AVF is inferior wall. V1 to V4, anteroceptor. V5, V6, one avial, lateral one. That is for ST elevation MI. But ST or non-ST elevation MI does not follow this. The ST depressions and T wave inversions are directly proportional to the amount of myocardium which is damaged, and this can be a diffuse phenomenon. The cutoffs for ST depressions are only 0.5. So this is something I want to impress on you. When you look at an ECG in such a patient, even half which is half small box depression, is significant. So you have to very, very carefully look at the ECG before you label it. More than 1 is specific, no doubt. But even a half depression becomes significant. T wave inversions, which are at least 1 deep, right, in more than 2 contiguous leads, which have predominant R waves and which are dynamic. That means you have an ECG from 1 day ago which had no T wave inversions, but today's ECG shows T wave inversions. Or 6 hours ago there were no T wave inversions, now they are present. This is called dynamic T waves. This is indication of myocardial ischemia. So this becomes non-ST elevation MI. A point I'd like to add here: ST elevation MI, refer for thrombolysis and PCI as urgently as possible. If you can't refer, or they have to stay in your center for whatever reason or logistics, dual antiplatelet loading dose. So aspirin 325, clopidogrel 300, atorvastatin 80 mg, sublingual nitroglycerin to reduce the anginal chest pain, provided the BP is well maintained and there's no heart failure. This is standard for STEMI. In STEMI, they do require an angiogram, but they don't require thrombolysis. So NST elevation MI, are you referring for thrombolysis? No. We don't thrombolyze them, but we do an angiogram at some point, right? An angiogram is required. These are patients where the cause of NSTEMI is the underlying COPD, the underlying pneumonia, the underlying renal failure, the underlying sepsis. NSTEMI is always triggered by something. Treat the trigger, but do an angiogram which will reveal some coronary blocks. But the acute treatment is again loading doses, yes. So aspirin 325, clopidogrel 300, atorva 80. But these are patients you don't thrombolyze. Instead, you give them heparin. So unfractionated heparin, 5,000 units subcutaneous every 6 hours. Or if you're giving low molecular weight heparin, you can give 1 milligram per kg twice daily. So subcutaneous. So this is extremely important to know, that you don't necessarily thrombolyze NSTEMI patients. As I showed you last time, a repetition, ST depression can come in 3 forms: upsloping, downsloping, and horizontal, downsloping being the most dangerous. And these are the patterns of ST depression that you can see. Right? All of these are the various patterns that you can see, especially the last one. If you see, it's quite subtle. It's not even one box. That's why I said even 0.5 of ST depression is significant. So you have to really look at an ECG carefully to pick up NSTEMI. The last ECG for ACS, I thought I'll just put this up. A middle-aged diabetic and hypertensive presents with exertional fatigue with class 2 dyspnea for 1 week. BP 150/90, pulse normal, respiratory normal, JVP normal, everything is fine. He's just got exertional fatigue. And he says, normally I walk about 5 km, now I'm not able to walk more than a km, I've got class 2 dyspnea. And this is the ECG that you see. The calibration on the extreme left is normal. The rate is good, it's about less than maybe about 65 or 60 is the rate. Axis is left axis because 1 is positive, AVF is negative. But what you're classically seeing here are T wave inversions. So you have T wave inversions in 1, 2, you see T wave inversions in AVL, V4, V5, V6. So this is a patient with a routine ECG with just fatigue and breathlessness, no anginal chest pain, but he has T wave inversions. And it's very important that all of you identify that T wave inversions are also very important to look at, right? Because as I said, T wave indicate myocardial ischemia. You need not be having a NSTEMI. This could be unstable angina. This could be early NSTEMI. So remember, T wave inversions are not to be neglected in the setting of a symptomatic patient. Why do I say that? Because you have certain patients who may be asymptomatic with T wave inversions. You evaluate them, it comes normal. But if they have ongoing cardiac symptoms with T wave inversions, never neglect them, because these T wave inversions could be indications of a deeper problem. So you have to be very, very careful when you look at T wave inversions. I'll just pause for a couple of seconds just to allow anybody, if they have, I know you'll ask questions in the end, but if anybody have any gross major doubts, they can ask me right away before we go into tachyarrhythmias. But this is basically what you need to know in ACS. Your key takeaways should be identifying ST elevation, identifying ST depression, and T wave inversion. So these are things you should unfortunately never miss in an ECG. If you err on the side of caution, I've had bonders who sent me ECGs where it's ST elevation, but it's 2 mm in a 25-year-old. 2 mm, but in V2, V3. Now I know that less than more than 2.5 is significant, right? Some of you may not know that yet. So they'll send me and say, sir, I thought this was MI, I loaded and sent the patient, but he's come back where the cardiologist said he's absolutely normal. Doesn't matter. This is how we all learn. You have erred on the side of caution, which is okay. You saw ST elevation, he came to you with chest pain, you referred. But remember, up to 2.5 mm is okay in a young patient, right? Repeat an ECG and look for it. Remember, when in doubt, an ECG is a dynamic indicator. So always repeat an ECG if you're in doubt. Never hesitate to do more than one ECG. So coming to tachyarrhythmias, and this is something I think is something I find that everybody sort of struggles with when they do make diagnosis on ECG. So what I have done over time is used a lot of guidelines to build up a sort of algorithm, which I'll show you. A revision of the cardiac conduction system. As we know, we have a sinoatrial node, which is our pacemaker of the heart. The SA node gives three internodal pathways of Thorel, Wenckebach, and Bachmann, which supply the left atrium and send signals to the AV node. The AV node sort of slows the impulses just for a while to allow the ventricles to relax, and then shoves the electrical signals down through the bundle of His, or the AV bundle. The bundle of His has two divisions: a right bundle, which supplies the right ventricle and part of the interventricular septum, and the left bundle, which supplies the left ventricle. The left bundle has two parts, an anterior and a posterior bundle, which eventually break down into Purkinje fibers. And these Purkinje fibers supply the myocardium. One thing I want you to know, and I've said this before, while the sinoatrial node is our pacemaker, please remember every myocardial cell has the potential to be a pacemaker. And this is something none of you should forget. The reason I say this is this: let's say the SA node is not functioning, another myocardial cell can take over as the pacemaker. So when we look at tachyarrhythmias, we don't look at the classification that you've learned in Davidson or Harrison of arrhythmias, which say tachyarrhythmias are based on, pathological causes of tachyarrhythmias, or what is the physiological disruption. Is it because of an aberrant pathway, because of a hyperexcitable pacemaker? There are various classifications. When you look at ECG classification of tachyarrhythmia, you are looking at only two things. And these are, I think, a very simplified form, but they are very, very useful to follow. You have only two things to look at. You look at the QRS and you look at the rhythm. And if you put them together, you get most of the 90% of the arrhythmias that you will encounter are covered here. Now, why am I saying this? Your QRS, as I told you last time, is the time taken for ventricular repolarization or activation of the ventricular electrical system. That is normally less than 3 small boxes, or 0.12. If your QRS is wide, that is more than 3 small boxes, the problem is probably in the bundle of His and below, which means that it's arising from the ventricles. And these are called ventricular arrhythmias. So whenever the QRS is wide, it means that the arrhythmia is arising from the bundle of His and below. Some people say AV node and below as well. And that is why it is wide, because it is arising from the AV node and below. If your QRS is narrow, that is less than 0.12 seconds, that means it's arising from above the AV node, supraventricular. So that is why arrhythmias are called supraventricular and ventricular. Ventricular are wide QRS, supraventricular are narrow. Is this exclusive? No, but 90% is covered by this. Now, supraventricular is nothing but atrial. What is above the AV node? All the atrial. So the problems are in the atria, we call them supraventricular. Problems are in the AV node and below, we call them ventricular. That is part 1. You're looking at the QRS. Part 2 is the rhythm regular. Every R wave occurring in a particular distance from the next, or is it irregular? If you club the two, right? You club the two, you get 4. You get narrow QRS regular, narrow QRS irregular, wide QRS regular, wide QRS irregular. Under each one, you have various diseases, right? So this is the ECG classification of arrhythmias. Now, I have further simplified this in terms of an algorithm which all of you can follow. But generally, when you look at arrhythmias, this is how they look. Okay, you will see. I'll give you a few common examples. Atrial tachycardia, atrial flutter, narrow QM plus regular. Atrial fibrillation, irregular, but narrow complex. Ventricular tachycardia, wide QRMs regular. Ventricular fibrillation will be wide QRS with irregular or polymorphic VT. So most of your arrhythmias will fit in one of these 4 boxes. This is your physiological classification, which I mentioned. Now, this is the algorithm which has been constructed. It's taken from an old British and American journal, and I've clubbed them together. Tachycardia means heart rate is more than 100. Okay, that we all know. So when you look at it, if the QRS is narrow complex, less than 120 milliseconds, right? It's called narrow complex. It means the origin is supraventricular above the AV node. And if it is wide complex, I'm sorry, there's a typo here. It should be QRS more than 120. It's called wide complex. So wide complex is QRS more than 120. Narrow complex is QRS less than 120. Sorry for the typo. If it's a narrow complex tachycardia, QRS less than 120, is it irregular or not? If it is irregular, you have few conditions. The most common for all of you is atrial fibrillation, atrial flutter with variable block, multifocal atrial tachycardia, atrial ectopics. All have the word atria in it because it is narrow complex. It can only arise from the atria. Your best examples are AFib and flutter with variable block. But if it's narrow complex, which means it's atrial in origin, and it's regular, then you further subdivide. Is it regular with P waves? That means before the QRS, are you seeing P waves or without P waves? If it's narrow complex, regular with P waves, your diagnosis is AVNRT or AVRT. AVNRT stands for AV nodal reentry tachycardia, which the best example is your classical PSVT, paroxysmal supraventricular tachycardia, is an example of an AVNRT. Or is it AVRT, which is atrioventricular reentrant tachycardia, inappropriate sinus tachycardia, where it is sinus, that is PQRST in sequence, but the rate is more than 120. That's called inappropriate sinus tachycardia. And then the last is junctional tachycardia, where the origin is from the AV nodal itself. These are regular, narrow complex with P waves. Then you have regular, narrow complex without P waves. And the best examples of these are usually your flutter, because you don't see P waves, you see flutter waves, and AVNRT variant, which is called PSVT, where the P wave is hidden. I'll show you an ECG subsequently. So with this narrow complex tachycardias, which are supraventricular, we have finished. I notice there's a little bit of a lag. I'll just switch my video off. Navnita, is that okay?
Yeah, yes, sir. Yes, sir. No problem.
Right, sorry for that. Coming to wide complex. So this is how you look at narrow complex. Irregular or regular. If it's irregular, these conditions. If it's regular, look for P waves. If they have P waves, these are the set. No P waves, this is the set. Coming to wide complex. And wide complex is quite easier than narrow complex for the doctor, not for the patient. If you have wide complex, that is QRS is more than 120, again, there's a typing mistake, I'm sorry. QRS more than 120 and it's irregular. Why more than 120 means the origin is in the ventricle. Irregular means it is either polymorphic VT or rarely atrial fibrillation with Wolff-Parkinson-White, right? Also called SVT with aberrancy. You will read in some textbooks the word SVT with aberrancy. This is a supraventricular tachycardia, but because there is the bundle of Kent, which is your Wolff-Parkinson-White, it is bypassing that and behaving like a VT. So polymorphic VT, ventricular fibrillation, AF with Wolff-Parkinson-White are wide complex irregular. Wide complex regular, monomorphic VT, SVT with aberrance, which is not due to Wolff-Parkinson, sorry, not due to atrial fibrillation. So SVT with aberrancy without atrial fibrillation will be regular. SVT with aberrancy with atrial fibrillation becomes irregular. So these are the two most important in wide complex. I know the slide looks a little complicated, but if you can remember all this algorithm, diagnosis of tachyarrhythmia will fit 90% into this. So it's quite easy if you follow this. So let's do it with cases and then you will be able to pick up the hang of it much faster. So case number 1, you have a young lady. She comes to you with 3 episodes of sudden onset rapid palpitations. She says, I'm sitting down, I get sudden onset palpitations. Each palpitation has lasted 10 minutes. I felt lightheaded during the palpitation. And as soon as the palpitation finished, I went and passed 500 ml of urine, which is very odd. When you examine her, she's having palpitations as you speak. Her pulse is 160 but regular. BP is normal. Respiratory rate is fine. But her JVP, you can see that it's not elevated, but the JVP neck veins are very prominent and you can see the heartbeat through them. This is the ECG. So if you look at the ECG of this lady who's come to you with this type of presentation, let us look at the calibration. The calibration is normal, 2 boxes tall, 1 box wide. The axis is right axis. One is predominantly negative, AVF is positive, so it is right axis deviation. The heart rate is about 300 divided by 2 big boxes, so approximately 150 is the heart rate. So now you have this type of patient. What is missing in the ECG? So you have tachycardia, you have right axis deviation. You can see QRS, there's no ST segment elevation, no ST segment depression. She's tachycardic, she's had 3 episodes of palpitations. If you look closely at this ECG, you will see that there are QRS complexes everywhere, but you cannot see P waves. There are no P waves in this ECG. So the moment you see no P waves, the first thing is, I've attended Chaitanya's medicine classes. He has said if there are heart rate, there are no P waves on ECG and absent A waves on JVP, it is atrial fibrillation. But then he also said that atrial fibrillation is the most common cause of an irregularly irregular pulse. Here it is absolutely regular. So what are we dealing with? We are dealing with what we call AVNRT. Now, how did I reach this diagnosis? Simple. I looked at the algorithm. I have a heart rate of 150, so my heart rate more than 100, tachyarrhythmia. Is it narrow complex or wide complex? The QRS is definitely about 2 small boxes, so it is narrow complex. Is it irregular or regular? It is absolutely regular. Are there P waves or not? There are no P waves. So therefore, if I apply the algorithm, my diagnosis is PSVT. Now you may say, so why no flutter? Because in atrial flutter, you will see sawtooth appearance of flutter waves, which we are not seeing here. In fact, here, if you look carefully, the P waves are hidden. The P waves are commonly hidden in V1 and V2, appearing like a R dash wave. This is called the pseudo R dash pattern. And if you look at the person's ECG, where my pointer is going to lie, that is the RP waves. So this is called the pseudo R dash appearance, classically seen in an AVNRT, presenting as PSVT, paroxysmal, because she's had 3 episodes, supraventricular tachycardia. If you follow the algorithm, you got your diagnosis straightforward. The treatment is very simple. Give her carotid massage, give her adenosine. So 6 milligram of adenosine stat, it usually settles with that. You can repeat another dose and go up to 12 milligrams. So this is PSVT. Second ECG. A middle-aged gentleman who's a known case of thyrotoxicosis. Nathaniel, you raised your hand. Sorry, go ahead.
So I just have a question with
Yeah.
respect to PSVT, AVNRT, and AVNRT. Is the
Yes.
mechanism different?
So good question.
Okay,
So
like
the fair enough. So AVNRTs, the problem is that there is a re-entry circuit within the AV node. You have a fast circuit and a slow circuit within the AV node itself. Now, this AVNRT can present in many ways. The commonest presentation is a regular high heart rate tachycardic PSVT. So PSVT is the most common clinical presentation of an AVNRT. But there are AVNRT can present with various types. You have typical AVNRT, you have atypical AVNRT, which present like this. But 70% of AVNRTs present like this, which is called a PSVT. So your ECG diagnosis will be AVNRT, commonest type PSVT. Because see, PSVT generally means paroxysmal supraventricular tachycardia. It doesn't tell you what the ECG pathology is. It's the clinical condition. AVNRT is the clinical condition. So you have various types of AVNRT. The most common is this.
So you can have AVNRT with the P wave as well.
Yes. So you can have an AVNRT with a P wave. Now that P wave is always after the QRS complex. If it occurs like I showed you in this ECG where it's like a pseudo R dash pattern, it's called a short RP tachycardia. RP meaning R wave to P wave. Sometimes in an atypical AVNRT, the P wave occurs along with the T wave. We call it a long RP tachycardia or an atypical AVNRT. So that is also possible based on the amount of re-entry circuit which is being activated at that particular point of time.
And you can have inverted P waves as well.
Yes, you can have inverted P waves if what happens is the AVNRT then sends retrograde impulses back to the atria. Then you can have inverted P waves, which tells you that the pacemaker is no longer the SI node. The pacemaker becomes the re-entry circuit itself.
Okay. Okay. All right.
So ECG2 is patients who have this patient has thyrotoxicosis. He's poorly compliant to his medicines, and he comes to you with 1 hour of sweating and sudden onset palpitations. You check the heart rate, and you find that the heart rate, the pulse is 75, regular, BP 110/80. His JVP looks elevated, no edema, but he's not he's not tachycardic. His BP is also quite regular. And then you look at his ECG. Right? Again, let's assume the calibration is normal, though it's not showing. You can see a left axis because one is positive and AVF is negative. It's a left axis deviation. Now, if you look at lead 2, which is the bottom, you'll notice that the QRS complexes are occurring regularly. The ventricular rate here, if you take it, the ventricular rate is 75. There are about 4 boxes, so 300 by 4 is about 75, which matches your pulse. But what you are seeing in addition to that is that before every QRS complex, you're seeing multiple waves. If you look at V1, you can see a T wave, 2 waves QRS, again T, 2 waves QRS. And if you look closely at V2, where my pointer is at, you'll see that the T wave in V2 has an extra sort of wave within it itself. And if you look at lead 2, both on the bottom and where the red arrow shows, you will see these multiple waves. Right? So this ECG is in a gentleman who's come to us classically with the heart rate being the ventricular rate is normal. Well, these abnormal waves are classically called flutter waves. So the waves that you're seeing in lead 2, you're seeing in 3, you're seeing in V1 are classically flutter waves. So then you'll ask me, sir, but you said in atrial flutter, the heart rate will be 250, 300, 400, 500. Here it is 75. That is the ventricular rate. Remember, when we talk about rate in flutter, we are talking about atrial rate. And if you calculate the atrial rate in this particular patient, it's barely 1 box. It's about 150, maybe 200. So in patients with flutter or atrial fibrillation, the atrial rate and the ventricular rate are separate, right? Because not every flutter or fibrillatory wave get conducted from the atrium to the ventricle. The problem is if it does, let's say you have an atrial rate of 150 and that every bit of that impulse gets converted to a ventricular rhythm, the patient's heart will beat at 150 and they will succumb to heart failure or a stroke, which is very dangerous. That's why the AV node prevents that from happening as much as possible. So in this patient, the atrial rate is about 150, the ventricular rate is 75, which means that not every atrial beat is conducted to the ventricle. And that is very important to know. This is the classical sawtooth pattern that you see in atrial flutter. Now, if I had to apply this particular algorithm, it's a narrow complex. It's about 2 small boxes. So yes, it's narrow complex. But then you will say, Chaitanya sir, heart rate is 75. All tachyarrhythmias have to have a heart rate of more than 100. So therefore, it doesn't apply. Again, remember, here, this is where there is a little bit of a gray area because this heart rate does not mean ventricular or atrial. So here, if you look at the ECG, the atrial rate is more than 100. So this algorithm still becomes relevant. So narrow complex, yes. Irregular, no. It is regular. with P waves, without P waves. Now you will tell me, sir, those waves look like P waves, but you are labeling it as without P waves because those are actually not P waves, those are flutter waves. Now, why am I labeling them different? Because P waves come from the SA node, flutter waves come from other parts of the atria, so we can't call them P waves, we have to call them flutter or fibrillatory waves. So therefore, this becomes regular narrow complex tachycardia without P waves, with flutter waves. Thereby, this is atrial flutter that we have. Okay. So again, with very atrial flutter, you can have variable AV block, you can have a fixed AV block, you can have a 2:1 conduction, 3:1 conduction, 4:1 conduction, various permutations and combinations. But identifying atrial flutter is very important. It's a classical ECG that looks like this, which you can't miss. This is how atrial flutter looks. The sawtooth pattern of inverted flutter waves in 2-3 AVF. You might see upright flutter waves like in our patient. The flutter waves in V1 look very like P waves, which is why all of you would have said, oh, those are P waves. But they're actually not. And the regular atrial activity can be up to 300. Which in our case, if you look at it, was approximately 300 because it is only 300 divided by one box. Ventricular rate 75, so 4:1 conduction. Coming to third ECG. We have a lady who's pregnant. She's got a past history of mitral stenosis, probably rheumatic in origin. She presents to the emergency with sudden onset left upper limb and lower limb weakness, diagnosed with a stroke possibly. Because this sudden onset of left upper limb weakness had after an episode of dyspnea and palpitations. She developed sudden onset breathlessness and palpitations and suddenly had left-sided hemiplegia. Pulse 135 irregular, BP slightly on the lower side, 94/76. The JVP had no A waves. You only saw a V wave and no edema. So when you look at the ECG, the calibration is well maintained, 2 up, 1 wide. Axis 1 is equivocal, AVF is positive, so it could be normal or right axis. If you look at the rhythm and you look at lead to right on the bottom, you will notice that all the R waves are not occurring at regular intervals. So you look at here, the gap between these two R waves is approximately 2 boxes. Here it's less than 2. Here it's 1.5. Here it's 1.5 again. Here it's 1 and 3/4. Here it's more than 2. So you will see that every R wave to the next, there is a change in the amount of interval. If you look at the bottommost, here there's a 3 squares gap. Here there's only 2 squares, again 3 squares. Also, not every QRS complex has a P wave before it, right? Very importantly, not every QRS has a P wave before it. So you have an irregular rhythm and not every QRS has a P wave before it. Also, the big red arrow shows V1. You can see some small waves. They're not fitting P waves, but you can see some small undulations in V1. You apply our algorithm. Narrow complex, yes, because it's less than 2 small boxes. Heart rate more than 100, absolutely. Irregular, yes. So since it is irregular, narrow complex, and you're seeing no P waves, the diagnosis is atrial fibrillation. You correlate that, relate that to rheumatic mitral stenosis. The commonest arrhythmia that you get in rheumatic mitral stenosis is atrial fibrillation. Can atrial fibrillation cause stroke? Absolutely. Clot from the left atrium goes into the left ventricle, goes to the middle cerebral circulation, causing hemiplegia. So this is atrial fibrillation. Those small waves that you saw are not P waves. Those small waves in V1 are called fibrillatory waves. You have fine and coarse, and they mimic P waves, and that's why it leads to misdiagnosis. So irregularly irregular rhythm, variable ventricular rate, no P waves, irregular rhythm, classical atrial fibrillation. Look for fibrillatory waves, they may be present. Last ECG for this particular session, or in tachyarrhythmias, a sports person collapses on the playing field. He is rushed to EMED unconscious, pulse of 200, regular, 60 systolic blood pressure, can't see JVP, no edema. This is your ECG. You see this ECG, again, the calibration is maybe not mentioned, or it is there. Assume the calibration is normal. Look at your axis. 1 is negative, AVF is negative, AVR is upright. Whenever you see one negative, AVF negative, it is extreme right axis deviation. I told you when you have extreme right axis deviation, it's either an error or it is a severely abnormal pathology in the heart. Look at AVF and you can see that AVF is, AVR is positive. Normally, all of us have AVR negative. Here, AVR is positive. You look at it, you can see that the patient has got a regular rhythm. The QRS is wide. If you look at the QRS, it is 1, 2, 3, 4 boxes. So you have wide QRS, tachycardia, extreme right axis deviation. I can't see any P waves anywhere. I can only see QRS T, QRS T, QRS T. So if I apply my algorithm, is it wide or narrow? It's more than 120. Sorry for the typo. It is wide complex. Is it regular or irregular? It is regular. Therefore, this is monomorphic VT. This is how an ECG of ventricular tachycardia will look. And as people who worked in the EMED or in the rural setup know, he's come unconscious, heart rate 200, BP 60, monomorphic VT. This is classical shockable rhythm. You have to give DC cardioversion to revert this patient to sinus rhythm and admit into the ICU for inotropic support and ventilatory support. So this is monomorphic VT. Now somebody asked me, sir, why can't this be SVT with aberrancy? There are some criteria to tell you, which I will come to. But remember, if you get an ECG like this, 8 out of 10 times it is monomorphic VT. It is unlikely to be SVT with aberrancy. So how do we differentiate the two? We follow Brugada's algorithm. Now, there is Vericke's algorithm, you have an American Heart Association algorithm, you have the Chinese algorithm, you have a Brugada's algorithm, you have a modified Brugada's algorithm. There are about 6 or 8 algorithms to follow. Now, this algorithm looks complicated because you need to look at the QRS, you need to look at an RS complex, an RS interval, AV dissociation to differentiate the two ECGs. And this is quite complicated. So what I generally teach is Brugada's sign. Okay? Not is Brugada's sign, not Brugada's syndrome. Brugada's sign is a very simple cheat. And the cheat is you look at AVR. You have a patient, you're not sure if it's monomorphic VT or SVT with aberrancy. Look at AVR. If AVR is upright, it is most likely VT. If you look at the two examples of ECG I've given, one above the other, the second one is the ECG we had, AVR was upright. But if you look at the other ECG, AVR is down. But it's still wide complex tachycardia. It still looks like VT. But because AVR is down, this is SVT with aberrancy. Here AVR is up. That's why this is VT. If you follow this Brugada's sign, which is the simplest of all, you will not miss differentiating the. Okay. So that is about tachyarrhythmias. I have oversimplified it. That algorithm and that table, I will modify the QRS, that mistake that I made, and I'll send you these slides. Just keep screenshots of that particular algorithm. You guys will never miss arrhythmias again. In fact, apart from second to acute coronary syndrome, the ECGs that I get on WhatsApp are most likely some type of arrhythmia. So you have to be very careful in identifying. Last part of today is just bradyarrhythmias. These are the simpler ones than tachyarrhythmias, but still need to be identified and looked at. So coming to bradyarrhythmias, typically when you have bradycardia, a heart rate of less than 50, you are looking at patients where the pacemaker is defective, that is the SC node. So the SC node is not producing impulses at the rate of 70 to 100. It is weak, so you have bradycardia. Or the SC node is working, but the AV node is preventing those impulses from going to the ventricle at the appropriate rate. You'll notice something in this classification, that AV blockade, junctional rhythm, and bundle branch block is mentioned under classification of bradyarrhythmia, but this is actually not really correct. Because AV blocks, except complete heart block, which you see, the rate is never less than 50. Your Mobitz type 1 and 2, you never get bradycardia. But these are counted under bradyarrhythmias. So you may get a little confused when you read cardiac textbooks. Don't get confused. Not all bradyarrhythmias need to have bradycardia. They are classified under that. Coming to ECG1. Calibration is normal. This is a routine ECG. Patient has come. So calibration 1. So patient's calibration is okay. The rate, if you take lead 2, there are about 3, 6, 8 boxes. So 300 divided by 8. So your rate comes to somewhere about 37.5. Right? So your rate is very low. 37 is the heart rate, which means extreme bradycardia. In addition to that, you will see that the axis is normal, no ST segment elevations, everything looks normal. But you will see some type of wave. If you look very carefully, you will see a small wave in V2, you see it in V4 and V6. Right? These are called U waves. So U waves, as I taught you, classically we see them in hypokalemia, but they can be seen in extreme bradycardia. So the diagnosis of this ECG is sinus bradycardia. Why sinus? Because every QRS is preceded by a P wave. So this is sinus bradycardia, which means your SA node is not functioning properly. It's producing cardiac stimuli at a slow rate. Best example is hypothyroidism, myxedema, heart rate low. SA node dysfunction due to dengue. This is ECG is in fact somebody from dengue. Dengue causes SA nodal dysfunction, classically a low heart. Second ECG. Again, here the calibration is normal. Axis 1 AVF is okay. If you look at the rhythm right in the bottom, it doesn't look regular. Every QRS has a P wave before it, so sinus rhythm is for sure. But see, there is a 8 box gap here. Then it is 3.5, 3, 4, 4, 4, 4, again becomes 8. So you will see that the RR interval is not really constant in all of these. There is a variation, but every QRS is preceded by a P wave. This is the most common arrhythmia that all of you will encounter. The diagnosis is, if you see this, second most common arrhythmia that you will see, where you don't see a P wave for 3 seconds. If you calculate 1, 2, 3, for 8 boxes almost, you are not seeing a P wave. So whenever you get absent P waves for more than 3 seconds, it's called sinus arrest. This is called sinus arrest. It's the second most common bradyarrhythmia seen after sinus bradycardia. I'm not sure how many of you have encountered this, but here the RR intervals are varying and there's an absent P wave for 3 seconds. This is called sinus nodal arrest. If the P waves are absent for less than 3 seconds, it's called a sinoatrial exit block. Forget about it. Just remember sinus node arrest. No P waves for 3 seconds. Everything else looks normal. Next, this ECG calibration is normal. Axis is normal. Everything looks okay. But if you look closely at lead 2, you will notice that there is a gap. There is a gap between the P wave and the next QRS. I have demonstrated in AVF, but ideally you should look at it in lead 2. You can see that from the beginning of the P wave to the beginning of the QRS complex is approximately 6 boxes. The upper limit is 5 boxes. So the PR interval is more than 0.2. But every QRS complex has a P wave before it. So PQRST, 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 just that the PR interval is prolonged, isolated. This is called Mobitz type 1 heart block. So this is Mobitz type 1 atrioventricular block. It's type 1 atrioventricular block because only the PR interval is prolonged. There's no dropping of the P waves. There are no STT changes, no problem with the QRS. These are patients who are asymptomatic, nothing to be done. Just monitor them once in 6 months. But you look at ECG number 4, again, calibration normal, axis okay, no dramatic STT changes. But if you look at lead 2, which is your rhythm strip on the bottom, you will see some findings. I have zoomed it. I've taken a strip of lead 2, and this is what you see. This is the PR interval. This is approximately 1, 2, 3, about 5 boxes. PR interval, 6 boxes. PR interval, 7 boxes. PR interval, 7 boxes. PR interval between P to P. This is not PR interval. There is no R wave here. So you see here, PR interval, 5 boxes, 6 boxes, 6 boxes, 7 boxes, and then you don't have a QRS complex. You instead have 2 P waves. So here you are seeing that the PR interval is progressively lengthening till it drops a beat. That is, one beat doesn't get conducted from the atria to the ventricle, that is called a dropped beat. This is type 2 AV block, Mobitz type 1. Type 2 atrioventricular block, Mobitz type 1. I'm sorry, I called first degree AV block Mobitz 1. I'm sorry, that's a mistake. The previous ECG was first degree AV block. This is type 2 AV block, Mobitz type 1. Because in type 2, there is Mobitz type 1 and type 2. This is Mobitz type 1. Here you will see that the PR interval progressively lengthens till the QRS drops. The QRS usually drops at the fourth or the third impulse. From patient to patient, it varies. This is Mobitz type 1, second degree heart. The next ECG obviously is Mobitz type 2, but pay very close attention. If you look at the bottom of the ECG, which is lead 2, and again I have zoomed in one part, you will see a PR interval, and roughly this is about about 5 small boxes, so the borderline. So 5 boxes, and then it drops a beat. Again, 5 boxes, and drops a beat. So here you see that the PR interval is slightly prolonged, and the beat is getting dropped with every third beat, right? But there is no prolongation of the PR interval. It's a fixed prolonged PR interval. It doesn't prolong with each beat, but there is a drop beat occurring here. So when you get a beat missed or dropped with a prolonged PR interval, which doesn't keep prolonging with each QRS complex, there's no successive prolongation. It is a fixed prolongation. This is Mobitz type 2, second degree AV block. So in Mobitz type 1, you had PR interval is prolonged, but it keeps getting more and more prolonged, more and more prolonged, more and more prolonged, drops a beat. But in Mobitz type 2, the PR prolongation is fixed and the misbeat occurs every second to third. This is very dangerous because if it is type 2, Mobitz type 2, the risk of going into complete heart block is very high. The last ECG of bradyarrhythmias is quite simple. Patient has got calibration okay, access is fine, extreme bradycardia. The heart rate, if you look at the ventricular rate here, it's approximately 30, less than 30, it's about 25. And you will see here that there are multiple P waves. All the red arrows are P waves, all the blue arrows are QRS. So in the same ECG, you have a ventricular rate of about 25-30, and you have an atrial rate of about 75 to 100. And if you look at it, the QRS complexes are occurring separately, the P waves are occurring separately. There is no synchrony between PQRS. I always told you in an ECG, PQRST maintains the pattern. Here, you're not seeing any pattern. The atria are beating separately, ventricular are beating separately. This is called AV dyssynchrony, classical of a complete heart block. This is the ECG of complete heart block. See how deep the T waves are. This is called Whelan's sign. So this can be seen in patients with severe MI or sometimes raised ICT. This is Whelan's sign or deep T waves, complete heart block. So Mobitz first degree AV block, prolonged interval with a fixed delay. Mobitz type 1, prolonged interval with a non-conductive P wave. Mobitz type 2, intermittently non-conductive P wave without a progressive prolongation, and independent rate becomes third degree. Okay. So there are some miscellaneous ECGs which I will skip because I'd like to discuss some of the ECGs that people have put up. So this is about bradyarrhythmias, tachyarrhythmias, and ECGs in ACS. Over to you, Navita.
Okay, hi. I will put up the feedback form in the messages now so that you can fill them up. And we'll take a short 5 minutes break for you to fill that up, and then we'll come back and discuss the ECGs. In the meantime, if any of you have any doubts, you can put up in the chat box or the WhatsApp group. We can discuss that as well. There has only been 3 responses till now. It just takes a minute for you to fill that. It would be really helpful for us if you could do that, please. Thank you.
I think Veena had a question. Hi, Veena. When we see heart block, when do we refer? That's a good question. I think if you're dealing with type 1 AV block, even Mobitz type 1 AV block, second degree AV block, if the patient is not symptomatic for it and it's a routine pickup, you can afford to wait and get them a cardiac evaluation subsequently. But Mobitz type 2 and definitely Mobitz type 3, sorry, type 3 AV block require urgent referral. The reason Mobitz type 2 requires referral because it can always go into complete heart block. And complete heart block requires urgent referral because they usually require a pacemaker, either a temporary pacemaker or a permanent one. When you're talking about SA nodal exit blocks or sinus wave arrest, which I showed you, those also require referral because these are patients who can develop severe bradycardia, which can cause compromise to the blood circulation to the brain, recurrent syncope. They can come with, TIAs, or even some rarely we've seen patients who come to us with stroke after a complete heart block. So these are the scenarios where you'll want to refer them urgent.
Thank you, sir.
So we can continue with the discussion. I think we've got 8 responses as of now. Hopefully people will give us the response once the class is over.
Sure. You have those ECGs, or shall I put them up? The ones that you sent me, do you have them with you?
I have not put them.
Got it. No problem. No issues. I'll try and put them up. I'll just see if I can share my share it on the chat. I'm just trying to check if I can forward those ECGs to the chat so everybody can see. Do you have it on your laptop by any chance?
Yes, I do have it. I can put it up in the WhatsApp group. I am not sure
Yeah,
how to
if
put
you
it
could do
up
that.
in this chat.
No, but let me just get it out of the chat. Should be okay. I'm just sharing it to the WhatsApp group. I think I should be able to have it on. Just share my screen and show it. Right. Just see if I can share it on this. Yeah, got it. Sure. I'll just share my screen. Right. So this is the first issue that they sent me. Can't flip it. Yeah, this is one ECG that they sent me. Anita, the screen is visible, right?
Yes, yes, yes.
Yeah. So this is an ECG that was sent to us to discuss. So again, the calibration, if you look at this, this is the commonest thing that I see is a very narrow calibration, right? So it should be at least one box wide. It's actually only here less than half a box. So that's why your complexes can look a little narrower than they should. The rate's about 100 if you take it. The axis, if you look at AVF is positive, lead one is equivocal, so we leave it as a normal axis. If you look at V1 and V2 in this particular ECG, there's a RSR dash pattern. This is the classical bunny ears of a right bundle branch block. Right? So classically, this is the bunny ears appearance of a rabbit ears appearance. It's seen in right bundle branch block complete. But what is interesting in this ECG is the AV block. If you look at the P wave from the beginning of the P wave to the beginning of R wave, there's about 6 boxes. So this is the first 6 boxes. And if you look at lead 2 in the bottom, the PR interval remains steady and there are no dropped beats. So because of that, since there are no dropped beats with a steady PR interval, this is first degree AV block. So here there is a first degree AV block. There is a right bundle branch block as well. So RBBB with first degree AV block. So some people call this bifascicular block as well. So this ECG is called a bifascicular block. I'm sorry that the ECG is inverted, but if you look at this particular ECG that they've shown us, you will see that the calibration is quite okay. The axis one is positive, AVF is positive, so it's a normal axis. The rate's about 100. The rate looks a little irregular, and I can't make out definitive P waves in this particular ECG. And I can see a ventricular premature complex. This large abnormal complex is a VPC. So it's a narrow complex tachycardia. It is somewhat irregular. I can't see any P waves. I can see an occasional VPC. I'll need to look very carefully to see any fibrillatory waves before I label this as a possible atrial fibrillation. But I would expect a slightly more irregular rate in atrial fibrillation. The other ECG, this you can easily make out that the rate is quite high. The rate's about 150, calibration okay, normal axis. You can see occasional VPCs here. Again, here you can see some P waves in this particular ECG, but the P waves are hidden in most of the leads. So again, this is a narrow complex tachycardia, irregular rhythm, no P wave. So I would be looking at an AVNRT. Again, Nathaniel asked earlier the other variants of how AVNRT looks. Nathaniel, this is one example. It doesn't look like a classical PSVT. There is some amount of inter-RR wave variability. So this is how an atypical AVNRT may look. So those are the three ECGs that were sent to us. If anybody else has any queries, any doubts, you can put your hands up and ask. As I said, ECG reading is an art, especially tachycardia, tachyarrhythmias, and ACS identification is quite difficult for most people. But if you follow the slides that I've put up and you just follow that pattern of ECG reading, you will never miss any find.
Okay. Okay, Nathaniel has a question.
Sir?
Hi, Nathaniel, what's up?
Yeah, hi. No, the question was with respect to suppose you've got patients with pacemakers, will you still have a normal sinus, as in you'll have the P wave as well, or will you just have a QRS firing from the pacemaker, or will you have inverted P waves?
Okay, that's a good question. Nathaniel. It again depends on what type of pacemaker we're dealing with. Some pacemakers, which are basically put into the heart, which are permanent pacemakers because of severe SA nodal dysfunction or a complete heart block, they are constantly firing, and there will always be a pacemaker wave, which is a thin, slender line. It's just a line. It's not even a wave. It's a thin, slender line followed by a QRS. You will get a thin, slender line followed by a QRS. The P wave is usually retrograde activation. So the pacemaker will activate the ventricle first and then the atrium. So you will get a retrograde P wave, but that P wave is usually hidden within the QRS. So you may not see the P wave; it will be hidden. So you'll see a slender you'll see a slender pacemaker wave, and then you'll see a broad QRS. The P wave is usually hidden. In some of the most sophisticated pacemakers, which have a lead in both the right ventricle and the right atrium, to ensure that there is no dyssynchrony between the ventricle and atrium when contracting and relaxing, you may see a pacemaker, a tiny P wave, which is inverted, and then a QRS. So you may see both pattern, but generally it's pacemaker, QRS with a P wave hidden within.
Okay. And if you want to know if like the pacemaker is not firing, will it go back to his heart block rhythm? If he's been inserted for a complete heart block and the pacemaker is not firing, would it go back to a complete heart block rhythm, or would it be having another unusual rhythm, particularly like if the pacemaker is not firing at the right rate?
Got it. So again, if you have a complete heart block, you put in pacemaker hoping that that's going to work, and it doesn't work. Two things can happen. In most cases, the patient goes back to the underlying rhythm, which is the complete heart block rhythm. So because the pacer is not working, the complete heart block will unfortunately persist, and they have rhythm. Very rarely, if the pacemaker doesn't function, but the pacemaker leads, it's called a wandering pacemaker. Sometimes the leads get displaced, etc. They can cause other parts of the heart to get stimulated because of the wandering leads. And rarely that can have, in addition to the complete heart block, they can have multiple ectopics. So we have seen patients whose pacemaker is not functioning coming back with not just a complete heart block, but other VPCs and APCs also, which can be life-threatening. But generally, it reverts to the prior rhythm.
Okay. Look, this actually came from a context of I had a patient recently. I'm right now working in vascular surgery. So he was going home on discharge, and then he had a fall. I mean, basically had a syncopal episode. He was on a pacemaker for complete heart drop, but his ECG in hospital was did not show like the P waves initially. It showed the pacemaker with like QRS complex, which was firing at around 90 ventricular rate. But when he had that fall, syncope, but the part of the reason I was a little unsure is why why was the rate going down to 50? And then I looked at the ECG and I could see P waves, and it was not, which was not there on the early ECG when he was admitted.
Correct.
So I just wanted to know how the around pacemakers how it work, because I'm not very.
Yes.
I mean, I'm not
Yes. So
very
probably his
confident around
pacemaker
it.
was possibly his pacemaker was dysfunctional. So what then happens is then the SA node again tries to take over, but there is a complete heart block still. So even though the SA node is firing, the heart block still persists. So that's why you usually revert back to your old rhythm, or you can develop atrial ectopics as well, or atrial or ventricular. Sorry.
Okay. All right. Anyway, thank you.
No problem.
Okay, Jitin David also raised his hands, but then do you still have a question? You can put it up in the chat box as well.
Oh, sorry, I don't have a question.
Not Nathaniel, this Jitin. Jitin David. Okay. So I think we have come to the end. Okay. Veena Mary.
Yeah. Sir, I have a question. Midnight patients used to come with retrosternal pain or chest pain. We do a ECG. Sometimes ECG may not show any like MI symptoms like that, sir. So, what is the drug of choice to give a painkiller? Tramadol you prefer, sir, or what? We are also a bit scared, sir. Resembles gastritis, but diabetic patient they will have a asymptomatic. So, what you advise, sir, in practical point of view?
If your ECG is normal and you don't have any evidence of an ongoing ischemia, so there are no T wave inversions, there are no ST elevations, ST depressions, it's a normal ECG, but they still come to you with nocturnal retrosternal chest pain. 3 or 4 things come to mind. One, as you said, acid peptic disease, say esophagitis, acid reflux, one possibility. Second possibility is something called nocturnal angina, which can occur, but that's usually seen in patients who've got aortic regurgitation, sometimes severe coronary artery disease. They can have nocturnal angina, but the patient will be symptomatic through the day with angina, getting worse at or having episodes at night. The third possibility is a musculoskeletal type of pain, which is what you would deal with. Again, if you're looking for pain relief, I usually prefer to try paracetamol before I go into try tramadol. The reason is tramadol sometimes has emetogenic potential, so vomiting may actually worsen if it's gastritis. So usually pantoprazole first, then maybe paracetamol would be my first choice, provided I've ruled out a cardiac issue. In lieu of today's class, one thing to keep in mind: a normal ECG does not mean no ACS, and that's something that you should keep in mind. Diabetic patient, elderly, come in the night with retrosternal chest pain, ECG normal. Don't label it and say, okay, this is gastritis and send it. It's always better to keep them for observation. Give your gastritis treatment. Do a repeat ECG after 30 minutes. If you have a tropi, nothing like it. When we do take ACS for you at some point, I'm sure there'll be an acute coronary syndrome class. There's something called rule in chest pain, rule out, right? So patients who have chest pain symptoms with a normal ECG, ideally TOP-I should be done. If you can't do a TOP, at least a serial ECG is a must before you discharge them, saying your pain is non-cardiac. So that is something to keep in mind.
Yes, sir. Thank you so much, sir.
No problem. Jitin, you asked any harm in giving loading dose? No. If you want to give a loading dose for a patient and you're suspecting MI before referring them, there's no real harm. There's not going to be any harm giving the loading doses. But after the loading dose, you have to be very sure that you're going to refer this patient either for an angiogram or angiogram angioplasty, or for a thrombolysis. So when you're giving the loading dose, you're going down the ACS pathway and sending. Let's say you give the loading dose and it turns out to be, the TOP-I comes negative, or the patient comes back from the other center with a repeat normal ECG and symptoms are very weird. There's no real harm. But again, generally giving loading doses of these drugs can cause a little bit of gastric irritation. But apart from that, no. But always be careful when you give these drugs before you start, because you're committing that it is an ACS.
So just another question: how well is heart score in determining a possible ACS in atypical chest pain for patients with atypical presentation?
It's actually quite, so if you look at the studies which they've used the heart score, so we have the heart score, you have the TIMI score, you have a Cincinnati score. So before TROP-I came in, and this is something that may be useful for the bonders, so I'm glad Nathaniel brought it up. There used to be something called the HEAR score without TROP. The T is TROP, so without TROP, and that didn't perform great. But what it did was basically it helped you say that okay, patient's got ongoing cardiac chest pain, uh, but ECG is not very conclusive, right? And then you applied this score. It sort of helped you rule out. You could say that the score was low. It did perform quite well. But the hard score is done quite well. If I remember the percentage is right, I think if it can do well, the sensitivity is about, I think, in the late 70s, 70%. So if you do have a patient who's got these type of tests, when you apply the hard score, you may be actually well worth, especially if you do have TROP-I with you. It may actually be quite sensitive in certain areas to allow you saying, okay, these are patients with ongoing cardiac or an ACS, potentially will be benefited with a PCI or thrombolysis. But since TROP-I is not commonly available in, say, the rural setting, even applying the HEAR score, while it's not as sensitive as the heart, is still, I feel, useful to use. But we have found about late 70s percentage is what the sensitivity of the heart score is.
Thank you.
No problem.
Okay, then if anyone else have a doubt, I guess we can discuss that over the WhatsApp group, because it's already closed sometime, right? So okay, let's conclude the class. Is that okay, sir?
Absolutely.
Okay, thank you all for joining in on this weekend. I hope you found this session useful. Of course, it was useful. I actually learned quite so many things, even though I've attended this class before. Each time you attend it, like, I really believe after you go through this, after you have understood the basics, I believe you should go and attend the class again after you have seen a few ECGs, because you will learn a lot more once you know some basics. I would like to extend my gratitude to Dr. Chaitanya sir for this amazing session. Thank you so much for dedicating your time. We'll be soon scheduling another class, and we'll let you know soon about it. As usual, a few things like the feedback form, which is shared in the chat box. It is already shared in the WhatsApp group. A few people have already filled it up. Please rest of you guys fill it. Also, we did discuss a few doubts. As you watch the video again, or as you come across a few ECGs, if you have any doubts, you can always put it up in the group. And in the academics groups as well as the discussion group, I know academics group have a lot of people. You can always put up in the discussion group so that sir can help you out with it. Thank you so much, everyone, and we'll meet you soon with the next class. And we will be uploading this class as well on our YouTube channel soon. I don't know when, but then soon. Thank you so much, sir. Thank you,
Thanks,
everyone.
Anita. Thank you, everyone. Thank you. Take care. Bye-bye.
Bye.